So without further ado, I'd like to introduce our speaker, Kim Hanson. Kim is the Executive Director of Diabetes Canada, and she'll be speaking on the 5 things happening in diabetes advocacy. Thank you, Kim, for joining us. It's an honor to have you, and I will pass the presentation on to you.
Thanks, Maureen. I'm so excited to be here and to be with you guys this evening or afternoon, depending on where you are. I wish we could be together in person, but this is the next best thing. So I wanted to talk to you guys about some things that are happening in terms of advocacy for people, particularly with type 1 in Canada. I wanted to talk quickly about the nationwide strategy that Diabetes Canada is advocating for. It's called Diabetes 360, and I'll talk about what it might mean for those of us living with type 1 and how it might help us live a little better with it when we get it implemented. I want to talk about some of the advocacy that we're doing for financial supports related to diabetes, medications, devices, supplies, as well as how we're advocating for what I might call human rights, employment rights, those kinds of things. And then I'll wrap it up by talking about how you might get involved if you're interested. At the end of this presentation, I'm going to have my email address that I'll show to all of you. So I would welcome your questions anytime throughout these remarks, but also if you don't have time or think of something after, please never hesitate to reach out. Our advocacy is wholly dependent on you guys telling us where you're running into barriers so that we can know where we need to help remove them. So Canada has a gigantic diabetes problem. Obviously, a lot of that pertains to people living with type 2. There are now actually 5 million Canadians living with diabetes and another 6 million who have pre-diabetes, which means that they have about a 50% chance of developing type 2 diabetes in the next few years unless something changes. Of that, 300,000 of us or so are living with type 1, and Canada is actually a bit of a hot spot for type 1. So the problem exists on behalf of all forms of diabetes in Canada, and it's continuously getting worse. People are really suffering, and it's costing our healthcare system a ton. Yet there is no way of coordinating, sharing best practices. There's no central database that even lets us know of those with diabetes in Canada who has type 1 and who has type 2, let alone how well are the different treatment protocols that we're taking working in managing the disease and preventing complications. And so we need to really build a data infrastructure, a way that provinces and territories can share best practices and improve their patient care pathways so that we're all getting the best care from the right person at the right time, regardless of where we live, and that access is equitable and economical. And that's really what Diabetes 360 is about. It has 4 targets that make up the 360. We say that 90% of Canadians who should be living in an environment that promotes wellness and does not promote the development of type 2 diabetes. We know that there's currently no way that we know of to prevent type 1, but at the same time, many of the things that we would do to help someone reduce their risk of developing type 2 diabetes, such as eating well, exercising regularly, getting good sleep, managing their stress, are also things that benefit those of us living with type 1 in terms of preserving our health. And they're not things that our normal lifestyle is particularly conducive of. So we need to put in place social supports, access to healthy foods, access to physical activity, regardless of socioeconomic status or where you live in this country, so that everybody is able to live more healthily. The second target is that 90% of Canadians should be aware of their diabetes status. For those with type 2, there are probably about 1 million who currently have diabetes and don't know it, and that really causes complications. It means that about half of them present with at diagnosis with complications already on board. But this has an important bearing on those of us with type 1 as well, because not enough healthcare providers understand enough about diabetes, its warning signs, the fact that you can develop type 1 at any age, and that 40% of us do develop it in adulthood. And that can delay some of us with type 1 from getting an accurate diagnosis even when we develop diabetes. And so we need to raise awareness. We need to raise awareness among the general public, and we need to raise awareness among healthcare practitioners. The third target is that 90% of Canadians with diabetes are engaged in interventions that help prevent complications. So that would be interventions in terms of the classic healthcare system, that you're getting the right care from the right practitioner at the right time, that you are able to access and use virtual and remote technologies even when we're not living in a pandemic, so that those of us that live at a distance from a major center can still get great care and leverage the tools that many of us with type 1 are using, our CGM data or our meter data or our pump data, to really optimize our diabetes management, even in between visits to the actual endocrinologist. It's also supports for self-management. You know, diabetes is an intensely self-managed disease, as we all well know. And so we need to make sure that every person living with diabetes has access to the medications, devices, and supplies that we need to live well, and that it's made available equitably and economically. And I'll come back to that later in this presentation. And then finally, we need community supports. We need people around us. We need events like this to help us manage the practical aspects of living with the disease, but also the emotional and mental aspects of it. So we want to help make sure that there's, for example, a patient portal that each of us could log into and maybe tap in our postal code and quickly get access to a range of supports for living with diabetes that could really make our day-to-day easier to manage, and that would be drawing on resources that aren't necessarily even within the classic healthcare system. So it can really help to sort of share the load of supporting people with diabetes in having the education and the other supports they need to manage their disease well. And then all three of those targets drive towards the achievement of the last, which is that 90% of Canadians who are engaged in those interventions are achieving improved health outcomes. So for us, that might be an improvement in time and range. At a population level, over time, we'll see a reduction in the rates of complications, kidney disease or retinopathy or those sorts of things. And we'll also see people reporting a greater sense of wellness living with diabetes. For type 1, that'll mean more funding for research into a cure and ways of managing the disease better. It'll mean, as I mentioned, a greater understanding and awareness of the important differences between type 1 and type 2, and that there's nothing that we can do to prevent or cause type 1, and that people can get it at any age. It'll mean improved access to care, medications, devices, and supplies, and overall better health outcomes. So it'll also result in significant savings to the healthcare system. A lot of that savings can come from helping to delay or prevent cases of type 2, but it also will come from hospitalizations and amputations and treatments being avoided for people living with all forms of diabetes. When we're having better care and able to better manage our diabetes, then we're going to wind up in ER less and having complications less, which helps save. So this strategy will more than pay for itself actually very, very quickly. Lots of Canadians support Diabetes 360. We've had more than 13,000 people sign a petition, and I'll show you where you can do so too if you'd like. We've had, during the election, the federal election last fall, we had more than 35,000 emails sent to candidates calling for them to support this strategy. We've had 15,000 letters sent to MPs since the federal election. An Ipsos poll that we did during the election showed that Canadians overwhelmingly support this kind of a measure. And the parliamentary finance and health committees have each recommended that it be funded in budget 2020. Now that was delayed due to the pandemic, but we're hoping that we will see funding for this program in the budget when it comes out sometime this year. If you'd like to add your voice to those calling for this strategy, it would be really helpful, a great way that you can advocate. Just visit diabetes.ca/strategy, press support now, that yellow button there, and just type in your name, your postal code, your email address, and it will automatically populate an email to your member of parliament, to a few key ministers, including the Minister of Finance, saying that you call for this strategy, you support it, and every person's voice counts. So this is a great way to get active right from your computer screen or your phone. Now let's talk about financial supports. So I'm going to ask you guys a poll question. Do you struggle to afford diabetes medications, devices, and supplies? The options are not at all, a little, or a lot.
We've got 85% voted, so I think I will share the results.
Great, thanks, Ali. Okay, so 53% of you say a little and 18% say a lot. So that's the majority of us who are feeling some pain trying to afford our medications, devices, and supplies. I'm glad to see that there are 30% who are not struggling at all. I assume that you guys have good private insurance, because we know that there are a lot of gaps in public insurance coverage, especially for some of the more advanced therapies like continuous glucose monitors and so on. Thanks everybody, I really appreciate your participation in that and your input. So we know that living with diabetes can cost up to $15,000 out of pocket each year, depending on where in Canada you live, what your income is, what kinds of therapies you're involved in. And that's a ton of money for anybody pretty much. In fact, most Canadians with diabetes pay more than 3% of their income out of pocket in a year, or over $1,500. And that's been defined as a catastrophic level of cost by the Kirby and Romano commissions. So that's a lot, and that's not acceptable. And so Diabetes Canada has been pushing on many fronts for many years to get those costs reduced and to get medications, devices, and supplies covered by public and private healthcare plans. We also know that because of these costs, 25% of Canadians report that they're not able to follow their prescribed treatment regimen perfectly due to the costs, and that's unacceptable. That has lots of long-term and short-term implications that we're not willing to accept. Now, I'm just going to give you a few examples of some programs that are available in Ontario. In each province, the programs that are available differ. If you'd like to get more information about them, you can email me, or you can call our 1-800-BANTING line, as in Frederick Banting, and my colleagues will put you in touch with programs in your province that might be helpful for you. But here in Ontario, we have programs for people to get coverage for test strips, lancets, glucose monitors. This one's contingent, I believe, on a lack of other insurance and on an income test. There's an Ontario drug benefit program whereby people can get support for medications if they're over age 65 or if their income is below a certain level. Same with the Trillium, that can cover maybe your insulin and so on. There's the ODSP program, which covers the cost of insulin and test strips, and may cover things like syringes and alcohol swabs and that sort of thing, again, for those whose income is lower. And for just that small section of people qualifying for the mandatory special necessities benefit, there may be coverage also for CGM. Ontario's just added Libre flash glucose monitor coverage under the ODB program just in the past year. And then finally, in Ontario, we have a program for insulin pump supplies. That does not cover the cost of CGM presently, but we at Diabetes Canada are pushing to have it included. I see that there's a question. I see that someone says they are fortunate not to require ADP funding due to private coverage. Would it be better to use the program or not in this scenario for the greater good of all type 1s? That is a great question, and it's a complicated answer. I'm interested to note that you're able to get your private coverage, notwithstanding, I assume you live in Ontario, if the ADP would apply to you. In my experience, many private insurers sort of require anybody claiming insulin pump supplies to prove that they don't have access to the ADP before they'll pay for it. When the government is a little twitchy about paying for things like CGM and insulin pumps because they're very expensive therapies. A lot of work has been done over the years to convince them that this is a good thing to protect people's health. So I would say if you're able to get private coverage, it's probably good to keep doing that. But if you ever have a problem, the ADP is there to help people. And in the case of Ontario, it's not age restricted. Thanks for the question. Someone else is asking whether Diabetes 360 includes advocating for Canadian universal health care. It is incredibly upsetting that Canadians have to pay for insulin, and we couldn't agree more. Yes, Diabetes Canada fully supports nationwide pharmacare. We believe that all Canadians should have access to the medications, devices, and supplies that they need to live well, and that it's important that the government close that gap. We have not yet heard enough specificity from the government about how they would propose to do that, to have a clear position on whether we agree with the government's proposed approach. Generally speaking, I think we would probably favor what we would call a gap filling approach, where it's a combination of private and public insurance that supports it, so that we make sure that the cost burden is shared across a multitude of players. And we would not want to see that by virtue of the introduction of pharmacare, that all of us have access to fewer medications, for example, or to fewer devices and supplies. I hope that helps, and feel free to write me if I didn't answer your question very well. Okay, so there are federal programs that apply to all of us in Canada. The disability tax credit, and I'll dive into that a bit more in a few minutes. It's a non-refundable tax credit, so that means that you have to have an income in order to benefit from this program. That's something that we've been arguing about with the government. But generally speaking, it reduces your income by about $1,500 a year. So that, or it can increase the amount that you get back from the government, or reduce how much you have to pay in taxes by $1,500 a year. It's also the gateway program to the child disability benefit. So that's for, in our case, kids living with type 1. Their parents may be able to claim the DTC for the child with type 1 and then get the child disability benefit, which can be up to $230 a month on an income adjusted basis to help cover the medical costs associated with that child living with an illness. And then the DTC is also an important gateway for the Registered Disability Savings Program, which is a super huge, awesome savings vehicle. Diabetes Canada was really active in the past few years advocating for fairness for the DTC. There was a problem, some of you might remember, in 2017 where the Canada Revenue Agency made an administrative change that stopped any adult with type 1 from being able to access the DTC. We stepped in partnership with JDRF and got the CRA to reverse that decision, which was great. That also caused the Senate to study the issue of access to the DTC and RDSP, and it resulted in the creation or reinstatement of the Disability Advisory Committee, which is a group of volunteer patient advocates and people who live with a variety of disabilities who have been advising the government on how to make the program more fair for the last year and a half or so. So the Disability Advisory Committee recently, about 6 months ago, I guess now, issued recommendations, and their recommendation that's most pertinent to us is that every person who requires insulin therapy to sustain life should automatically qualify for the DTC. And so Diabetes Canada fully supports that recommendation. We should just not have to apply at all. It should be automatic. And we're working right now really hard to try to get the Canada Revenue Agency to put that into practice. We have some ongoing issues that we're fighting for with respect to the DTC. We want people to just be made automatically eligible. That's point number 3 here. We also want to either do that or clarify the eligibility criteria so that we don't have to turn ourselves inside out to prove that it takes us an average of 14 hours a week to manage our diabetes. If you are having a problem with that, if your doctor won't fill out your form, if you are arguing with the CRA, you are not alone. Write me and I will help you. I will talk to your doctor. I've got tools I can share with you and we can help get you access to the program. But by and large, adults with type 1 who are on intensive insulin therapy, which is what they call it, which we all are, can qualify. So I'm happy to help. Diabetes Canada does a lot of things to help make sure that Canadians have access to the medications, devices, and supplies we need to live well. For example, when there's a new drug under review, a new kind of insulin, we provide patient submissions. We encourage that new medications are covered by the government. Right now, we're advocating that people not forcibly be switched from one kind of insulin to a biosimilar, something that's close to a biologic, but not exactly the same. That's a big issue in British Columbia and Alberta at the moment, and we're really working to say it's not okay to be just forcing people to switch. There has to be patient consultation and you have to work with their doctors. So that's something that we're involved in. And then the pharmacare debate, which we talked about a few minutes ago, that's something we're really closely watching and have been spending a lot of time with government talking about as they've been conducting their consultations on it. We've fought in a lot of provinces to establish insulin pump coverage where it exists but is age limited, to get those age restrictions moved. And now we're increasingly weighing in to get glucose monitors covered. These slides will be made available to you. I don't have an awful lot of time, so I'm kind of blazing through these, but I'm happy to answer any questions, as I said, after the fact. We've also been really involved in partnership with the Canadian Pediatric Society in advocating for supports for kids with type 1 so that they can go to school. There are guidelines, there are videos, there are tools that people can access to educate their child's teacher or other staff in the schools. And it's really important that every province and territory have a policy in place that ensures that kids with type 1 are able to go to school and be supported in managing their diabetes to whatever degree they need it. That's just what's fair, and so we've been fighting to make sure that that's in place across the board. And then human rights. I've highlighted here a couple where we've made some recent breakthroughs that I wanted to just point out to you. One is, you guys might have seen that last year, the first Canadian pilot who already had type 1 diabetes before becoming a pilot was able to get his commercial pilot's license, and he's now flying, I believe, for Air Canada Jazz, Austin McDonald. That was the product of many years of advocacy by a lot of people, and it was a big step forward for people with type 1. And in fact, the United States, just within the last 2 weeks, I think, has followed suit. So really big for people who are aspiring pilots. Just in the last couple of months, we've also found out that truck drivers who are taking insulin are now able to, without any problem, cross the US-Canada border. That used to be a barrier, and now that barrier has been removed, which is awesome. In the last year or so, I've been working with the RCMP to support them and encourage them to update their guidelines for people, for members of the force with diabetes, so that they're a bit more equitable and a bit more consistently applied. And I'm expecting that pretty soon we're going to hear good news from Canadian Blood Services that those of us with type 1 who are pretty healthy are able, if we want, to donate blood. So I'd like to know, would you donate blood if you were allowed? Yes, no, maybe so. I used to donate blood before I was diagnosed, and I miss it, and I would really like to be able to do it again. So I certainly would fall into that yes category, but that is not to sway anybody else's answer.
Okay, I think we'll end it. Yeah.
Great. 71% would, and another 6% would think about it. So that's fantastic. And of course, you know, no pressure. There are many good reasons why people choose not to donate blood, but I think it would be lovely for us to have that option again. So I'm hoping that we'll have that good news to share in the next couple of months. Stay tuned. So how can you get involved if you'd like to become engaged in advocacy? You might want to advocate on one of those issues. You might want to advocate on any of them or all of them. There are lots of things you can do. You can sign petitions. You can send letters to your provincial or territorial elected officials or to your federal ones or both. You can you know, be on social media and ask your personal and professional networks to do the same. Talk to them about why you support such and such an issue and ask if they would add their voice to it for you. In many cases, that can be a great way to educate people around you about what it's like to live with type 1, which is a great thing. If you feel more personal or personable about it in non-quarantine times, you can actually go to meetings with your elected officials to talk about how diabetes affects you and ask for the kinds of supports that would be most meaningful to you. Many organizations like Diabetes Canada have regular lobby days, we call them, where we go to the various legislatures or to Parliament Hill and bring patients and people living with diabetes or affected by diabetes to meet elected officials and lobby for what we need. So you can get involved in those. You can write me if you're keen to find out about that. And talk on social media, write blogs or op-eds for local media to share your experience. Someone's asking if there's any advocacy regarding access to new technology. For example, in the US, where they're trying to get interoperable devices. And so yes, I think that I've just lost that question, sorry. The answer I would offer you is that the first thing we have to get access for is CGM on all private and most public plans, or all public plans. That would be, I think, a critical linchpin in the sort of interoperability game. I'm not aware of any public restrictions that would inherently prevent that interoperability, but in order for interoperability to really work, you need to be able to have all parts of a system, and CGM is the linchpin. Somebody's asking, they said they didn't realize that you can lose the RDSP once approved. How does that happen? As I mentioned, the disability tax credit is a gateway program for the RDSP. And so you have to qualify for the DTC before you can open an RDSP. It used to be that if you were eventually determined no longer to be eligible for the DTC, if you lost your eligibility, you would be required to close your RDSP. And it used to be that the federal government would take back their contributions. So we fought pretty hard about that when we were fighting in 2017 and 2018. And I'm pleased to say that the government has changed that. So you can lose the ability to keep contributing to an RDSP if you lose eligibility for the DTC, but the government will not take back what you've already contributed or what they've already contributed. Write me if you've got more questions about that. And I see here that somebody's noticing that the Yukon has just announced that they're going to cover CGM, and that is true. And I had forgotten about that. That was just in the last couple of weeks, and it's been a bit of a blur lately. But yes, that was tremendous news. And I think that we should all be inspired by the example that they're setting in Yukon. And so how did they pull that off is another good question, but you can bet that we're connecting with those folks to see what was done, and we're going to be seeking to emulate that everywhere across the country, particularly as government starts to kind of get back to normal. So I think I'm just about at my last slide. If you want to get involved with advocacy, write to advocacy@diabetes.ca, or better yet, write to me. We've unfortunately had to temporarily lay off some folks because of the financial crisis associated with the pandemic. And so I would feel better if you emailed me, because then I would know that nobody's email was sitting in an inbox not getting checked regularly. But some of the issues that we've talked about today that you might advocate with us on are Diabetes 360, access to meds, devices, to quality care, and to rights and supports. So I was going to ask a poll. Do I have time to do that, or shall we? Okay, here's the poll. Maybe just a quick answer. What kind of advocacy would you be most likely to participate in? Email/letter writing? Do you feel brave and you might be willing on the right issue to get involved in an in-person or virtual meeting, particularly if it were set up for you? Or would you participate in lobby days or events, educational seminars, receptions, that kind of thing to educate legislatures? We'll just get the answer to this question, and then I promise I'll share my email and we'll wrap up and let you get to your next thing. I am impressed, you guys. There's lots of you that would be willing to get involved in person, and so that's phenomenal. Don't forget, even emailing, letter writing really counts. I won't bore you with the details, but officials have to log and respond to, on some level, every email and letter they get, so every little bit counts. But if you'd like to be involved, write me and let me know how, and we'll make sure to get you involved in the future. So thank you so much. It's been really lovely spending this time with you guys, and I hope to get to do it again. I look forward to connecting with some of you offline, and I hope that this has been a useful session for you. I would welcome any feedback on how I could make it better in future.
Thanks so much, Kim, and thanks everyone for sticking around. We've gone a few minutes over time. If you have to go, that's fine. I see that there's one more question in the Q&A folder, so maybe we'll address that one. And for any remaining questions, Kim has kindly shared her email there. So goodbye to those of you who can't stick around, and for those of you who can, we'll get to the last couple. Oh, there's other ones popping up, so there's a chance we might not make it to all of them.
I will do my best. So I see my friend Anna Kiff is noting that insurance coverage is able to get back some funds because of living in Ontario. So it's all good. So it depends on what else your private coverage covers if you can't afford it out of pocket. So absolutely right, Anna, thanks for that. It's really kind of individual, and if you've got questions, feel free to write us at Diabetes Canada or phone our 1-800-BANTING line if you want to know about programs in your province. My friend Brad Lee says, Ontario's Health Advisory Council has recommended funding for CGM. Where does that stand now, and what are next steps? That is a big step forward and great news. We were thrilled that they covered at least the flash glucose monitors, but we have been really working to make sure that even provinces covering flash understand that for some people flash isn't sufficient. And so we are, I was just meeting with some officials in the Ontario ministry just this past week. Right now, a lot of health decisions are kind of on hold while health ministries deal with the pandemic. But you may rest assured that we have not lost sight of the critical importance of getting CGM coverage. And as with anything, if the big provinces do it, the other ones tend to be more likely to follow suit. So we will be bringing that up. And when we do either a virtual or an in-person lobby day in Ontario this year, that will be a topic. So I'm happy to connect any of you who are still listening and are interested in weighing in on that event. I know I sure would like to see CGM coverage. And the last question is there data out there relating to the burden of type 1 complications, emergency visits, hospital admittance versus the cost of providing all of the tools and medications required? The short answer is yes. The longer answer is it's sort of patchy, and we have to either make assumptions to fill in those holes or pay a lot of money for health economists to gather data and analyze it in a way that's really sound. But the bottom line is that we know that even if CGM coverage could prevent 1,200 cases of DKA in the province of Ontario in a given year, it would pay for the estimated costs of covering it for all of us living with type 1 in Ontario. And that's the kind of data that we share with elected officials and policymakers when we're trying to advocate for programs like this. So that's just one example of a cost that can be avoided, but even that just makes it so worthwhile. So a great question. Yes-ish is the answer, and thanks for asking.
Okay. Sorry to jump in, Kim. Any other questions? Okay, thank you everybody for attending, and thank you so much, Kim, for first of all your advocacy and for this presentation today. It's been a great session, and if you have any questions for Kim, please write down her email address, and otherwise we will see you tomorrow.
Thanks so much, Maureen. Thanks everybody.